And I'm here to talk to you about the really boring bit that everybody doesn't want to listen to. It's ultrasound physics. Because everybody wants to get in there and play with the machines, and you think to yourself, why do I need to understand physics in order to do something like watch my TV? You know, you don't need to know how light beams work to do that, right? But this is ultrasound, and we're doing diagnostic imaging, and it's really important to be able to understand at least a little bit about how the machine works, so you can understand what you're seeing, and more importantly, you can understand what you're not seeing.
So I'll start with the LV function, LV assessment, and clearly we always say the LV is the most important chamber, is the one we need to know for sure, is the one that we really need to get into before moving on to the rest. In a way, it's true just for one reason, because we don't need to undermine the rest. But it's important because if you start your assessment from the left ventricle, if you start assessing what is normal, what is not normal on the left ventricle, then you can start moving around and comparing the right ventricle to the left or assessing the rest. So usually you start recognizing what is normal. And usually we start with the left ventricle. Also because the left ventricle is the chamber that in a way is dominant in our view. So it's difficult that you get a view where you don't see the left ventricle. So start assessing the left, see whether there is anything wrong. Because if there is anything wrong with the left, then you need to compare the rest with something that is already wrong in a way. So this is...
to talk to you about the RV and hemodynamics. Antonio just told you that LV assessment was the cornerstone of echo and POCUS. Well, this is the other cornerstone. It's not just one corner, the right ventricle. Critically ill patients in particular, the RV is really important. There's lots of implications for critically ill patients for all sorts of reasons which we'll talk about. Problems with the RV are going to very simply give you either impaired forward flow or impaired flow going into the right heart because of venous congestion. It can be caused by lots of things. So right heart problems can be caused by left heart problems, by lung disease, or by problems with the right ventricle itself. It can also be caused by things we do, the kind of ventilation we give to patients, our fluid management, etc. We always think about the LV and ejection fraction and stroke volume and all that sort of stuff, which is really important. But cardiac output has to be the same from the right side of the heart as it does from the left side of the heart. And so the RV is just as important as the left ventricle for cardiac output.
I will try to give you highlights of how to evaluate pericardial effusion and tamponade with point-of-care ultrasound. We will initially start with brief words on the anatomy of the pericardium. How do we see pericardial collection by point-of-care ultrasound? How do we assess tamponade? And how do we differentiate cardiac tamponade from the other mimickers of cardiac tamponade? And we will finish only by touching on the role of echocardiography in draining pericardial effusion. So cardiac tamponade is not entirely an echo diagnosis, it's a clinical and echocardiographic diagnosis together. We should always use the integrated approach. You will hear this from all of us frequently in this course because this is the foundation of performing point-of-care ultrasound.
This talk is designed to introduce a valve assessment to people that may not have met it before. And as you probably know, it's quite a complex area, this. And in fact, you know, assessing valves in the intensive care unit, if you're asking for, you know, what's the severity of this valve, you're probably asking the wrong question. I think what we're interested really is in what kind of valve problem might be impacting on hemodynamics right now. And if you're asking for what is the valve severity, you need to probably go to a level 3 cardiologist because the loading conditions that run through patients in ICU are so complex that you really need to know everything in the toolkit and more.
When I started to do lung ultrasound, which was more than 15 years ago, it was considered a kind of rocket science. So there was a large skepticism from the scientific community because lung ultrasound was mostly done by artifacts. But now if we get the latest ESC guidelines on heart failure, you can find lung ultrasound in the algorithm, in the diagnostic workup of the suspicion of acute heart failure together with echocardiography and chest x-ray. So we are in a new area and we really have to learn how to use this tool and include it in an integrated cardiopulmonary assessment.